That's going to be case in person. You ever met? You have, yeah, that's fine.
Well, good morning. Thank you for being with us for our second panel discussion of the day. Today, we're going to talk a little bit about telehealth. So again, I'm Rita Osborne, the Executive Director of the Utah Center for Rural Health and the Rural Health Association of Utah. We have our staff member Colleen Dempsey with us today of fame from our video this morning. And we have some amazing panelists with us today to talk about this critical issue of telehealth, especially as we're coming out of the pandemic. So we're going to let them introduce themselves to you and ask them to share in their introduction a little bit about the work that they're involved in. So you'll understand why we invited them to this discussion today. So Matt, do you want to kick us off?
Sure. Hello, everyone. Matt McCullough. I have really two primary roles. I'm the Director of Telehealth Services for the Utah Education Telehealth Network. So we're a state agency based out of the University of Utah in our administrative body. And we operate a broadband network that connects to almost 1,800 locations throughout the entire state. It includes every K-12 school, all the state libraries, colleges and universities, and what I'm responsible for is about 85 healthcare organizations, hospitals, clinics, public health departments. And the main thing is we provide their broadband internet and security services so that they can do telehealth visits and have cloud-based electronic health record and things like that. My other role is I'm the principal investigator for a federal grant. It's called the Northwest Regional Telehealth Resource Center. And it covers the Northwest region of Utah, Wyoming, Idaho, Montana, Oregon, Washington, and Alaska. So we have the biggest region geographically in the country. There's 14 telehealth resource centers.
And our TRC has a table in the ballroom.
Yeah, we have a table, and it's federally funded, so everything's free. It's all resources. I'd like to share a few of them with you, but the main one we just released is the Critical Access Hospital Telehealth Guide. The reason we're really excited about it is it has a multi-page telehealth program assessment. So if you're doing telehealth or want to get started in telehealth, it's a 60-page guide on things to consider in starting with telehealth. Yeah.
Can I just ask you about, it's a grant, so for how long and what's kind of a follow-up plan?
So this grant has been funded by.
It's a continuing grant.
It's a continuing grant. It's been around since 2007. So we have it right now for another 3 years.
But renewal.
Yeah, we renew it. So it's all resources. We have online training and education that has CME attached. We've had, since December of last year, we've had over 40,000 registrations for the course of telehealth training. So there's a big demand. The last thing I wanted to say was I spoke about a month ago at another conference, and I was speaking with another telehealth resource center director, and her first slide basically said that it's time to move away from thinking of in-person care versus telehealth, and to really get to a point where it's in-person care plus telehealth. And we're finding the specific areas where telehealth can provide as good or better quality for certain services where it's appropriate. And I really like that way of approaching telehealth. It's not this versus this. We're always going to do in-person care, so how can we augment that with virtual care and provide a better quality and better services to patients? So I just wanted to share that as my final thought.
Our next two panelists both are doing care, and so we'll offer a really unique perspective as well.
My name is David Zolman. I'm a licensed marriage family therapist. I'm also the director of behavioral health at an FQH center in St. George called Family Healthcare. So in my time when I started about 4.5, 5 years ago, I was one of 2 therapists, and now we have 8. So our behavioral health program has grown dramatically over the past several years, and now we have 13 medical providers. So that's been really good to have that hand in hand. And then over the course of this pandemic, the past 1.5 years or so, my role has included just testing out all of the telehealth platforms initially, and then finding a good fit for our providers, as well as something that works for the patients that we have. So that's been just part of my roles and responsibilities as far as that, from a clinical perspective, and then just continuing to work with patients and providers with any concerns that come up on a telehealth perspective, and making sure that we navigate those in a timely manner. Yeah.
And all of you providers do telehealth?
At one point, yes, they all did telehealth. Some of them now will probably only do 2 or 3 sessions.
Which is an interesting conversation, you know, some people really embrace it and others, you know, just naturally start to avoid.
And from the behavioral health perspective, all of them continue to do it because it's a little bit easier as we're not addressing physical needs, but we do have several medical providers that still have, you know, 4 to 6 chunk hours on their schedules each week.
My name is Dr. Zoe Robbins. I'm a doctor of nursing. I'm a psychiatric mental health nurse practitioner of many years. And I sought a job using telehealth because I got intrigued by this idea of being able to live abroad someday and still see my patients, and whether that's possible, you know, it's a whole other discussion. But it brought me to telehealth, and so I worked with the VA on their National Telemental Health Hub initiative, in which we started sort of coming in with red capes and saving the VAs, often rural VAs that weren't meeting their standards with behavioral health visits, and thus getting deemed nationally, and then you end up on the cover of the New York Times and you're not offered. And so we started, you know, this several years ago, coming in and sort of saving these little VAs. And at about that time, I was returning for my doctorate, from a master's doctorate, and I did my my doctoral project on educating psychiatric nurse practitioners in the benefits of telehealth. I was just trying to convince people that this could be something we could do, and the pandemic hit. And overnight, I'm also I'm an assistant professor of the psych DOT program at the U, and overnight I became kind of the, you know, this belle of the ball. I knew telehealth, and so I got invited to do some really projects, one of which was creating a course, really an extensive curriculum for primary care providers using telehealth. Worked on it tirelessly last summer. It's really valuable, and it actually is hosted on the NRTRC site as something that anyone can access. And it says primary care, but it's just good basic information. And now I am into a new opportunity, the state of Utah, in an attempt to expand services to rural communities, offered the psych doctoral nurse practitioners a chance to figure out how we could use money to access rural patients. We decided to do telehealth. So I am currently on Mondays seeing patients at Four Corners in Price virtually, with the idea, the design that we will identify a nurse in that community that would make an excellent nurse practitioner, psychiatric practitioner. I help, you know, pipeline them into the University of Utah system, and then I send them back to their own community, where I then give them their entire patient panel that they've spent their 3 years in school, you know, learning to work with under my advisement, my precepting. So that's the design, and we'd love to do that in many communities. And I'm going to use this as a shameless plug to say, if there are nurses that would make great psychiatric practitioners in rural communities, please send them my way. That's by design. We'd like to at least have a percentage of our cohorts, rural nurses that are going back to the community. Finally, I'll say I am under the tutelage of Matt as the chair of the Utah Telehealth Network, and Casey Shakespeare, who you all know, is my co-chair. And that's been really fun, because we just get to invite telehealth stakeholders, of which there are many in lots of places we don't know about. We're not a cohesive community yet. So you just hear about someone doing an amazing thing and get to say, hey, come hang out with us at Utah Telehealth Network group and tell us more. It's still real grassroots, and And yet it is the future of world global healthcare. It's so exciting. I really do still get very excited about it because I didn't expect in my lifetime to watch an entire new system of delivering healthcare in the world. And here I am, like on the front lines, part of it. It's exciting stuff.
Well, all of our panelists today have suggested that they're willing to take questions throughout this. We would love this to be a conversation, so please feel free. But we're going to start by asking them, what are some of the challenges and barriers, especially, let's talk about patients. What are some of the barriers for patients and then barriers for providers in utilizing telehealth?
Well, I'll tell you what I put in my curriculum for my students as a telemental health is my specialty. And it works well in behavioral health. I mean, it was obvious. And really the only thing that stopped behavioral health from doing telehealth long ago was insurance, is that you just couldn't get reimbursed. We always knew that it would work. But so now we're getting to practice what we knew we could do. But you cannot smell a patient. You often don't have a camera that can watch, unsteady footsteps, and you constantly have to make sure that maybe your paranoid clients still, feel safe in this digital environment where it's very easy to assume you could be recorded and who knows. So I have found that while I go into homes in one of my settings, I have to choose wisely because there is a lot of opportunity to maybe hide things, but then again, there's also opportunity to see things if you're in someone's home. But if you are working with a chronically ill population, one that really need eyes on the ground, you must build up your community system so that there is a physical space or an MA and a nurse and everyone collaborates. That's this idea that a provider from Salt Lake can just zoom into anyone's home and it's going to be a worthwhile visit. That's a little naive. And so it needs to be both, and you need to really think clearly about what patients are appropriate for home and which you still need to walk into a building and have a nurse do their blood pressure before you visit with them.
I would say from my perspective, early on, what we noticed is just the technology, right? A lot of, especially at an FQHC where we have a lot of patients that are uninsured, they might not have, a smartphone where they have that capability to download an app. And so what we ended up doing is that was the first thing we probably noticed was the technology. So we're like, well, as much as everybody loves Zoom, and we refer that to everyone, we found a lot of problems with that initially, just because the patient had to download it on their phone and didn't have that capability. So then we found a different platform called UpDocs where we were able to use that because it doesn't require anything other than a link. And then for those patients that didn't have that, they could come into the clinic and use one of our tablets. So we would then walk a tablet out to their vehicle. So that way we still do virtual. And of course, that means they would have to have the means to get there virtually that way. That probably doesn't happen nearly as often anymore. Either A, because they don't need to, and the pandemic is where it is today. I want to say the word over, but we're definitely not there yet. But also that they know someone who does have some type of device where they can log on. From the provider's perspective, continual issues that you'll notice is just waiting, right? Where before, if you go room to room and the patients are waiting for you, well, sometimes with telehealth, you are waiting on the patient, right? You mentally, you're waiting for them to log on. And so it feels like just a little bit more of a waste of time for some, which is why I think we have several providers that say, I will do it for 3 to 4 hours, not periodically as the patient requests during the day, because then you get behind with other patients that are nice.
So just a few barriers. So we primarily support providers in their efforts to do telehealth. And so beginning with adequate internet speed and definitely in rural areas, that is a challenge. We have areas in Utah that still don't have fiber into those communities. In a few cases, we're actually using microwave radio So radio towers up on top of mountain peaks that are basically beaming the internet wirelessly down to clinics, because there's no fiber. And so we're continually working on expanding the network and trying to build fiber out to communities.
And we're doing well, right? Utah really is setting the pace for a lot of the West in laying down fiber optics. We have good systems, but I think other.
Yeah, that's a good point. We talk a lot about patient and provider engagement in telehealth. I read I shouldn't say humorous, but it's kind of humorous, an article recently about a survey of patients and the distractions that they had, that they were causing during telehealth visits. 20% were on social media or gaming during the telehealth visit. It went through a list of things, including driving their car. I think it was 8 or 10% were driving their car when they got the notification on their phone that the provider's ready to speak to them. So, and we talk a lot about engagement, and you've probably heard the term website manner now, similar to the bedside manner, what we call website manner. How to actually engage patients and make sure they know this is a legitimate visit with the physician and they need to be ready for it.
And it's such a partnership. It's a totally, in some ways, a different kind of medicine, because you just cannot do your job for them if they aren't coming in almost with equal partnership. And that's a little bit new. I think patients are accustomed to walking into a building and being led here and you sit down, and it's just not that way. So there really has to be a lot of partnership in that effort.
So when you talk about the rural patient, what are the distinct differences between some of the urban, or even in Washington County, you get very suburbanized patients? Where do rural patients really struggle? And I know you've talked about trust, building trust with the provider, and that's the first visit, things like that.
I'm glad that you brought up trust, because I think it's easier for those patients that are in the more rural settings to have a place to go where they can start to establish that trust, that connection, saying, no, I know I can trust you. If it's virtually, I'm not going to be worried that my provider is distracted by X, Y, and Z, and the same with the provider to the patient. I think one of the things that, if I could do anything differently, which we're trying to work on as an agency ourselves, is having some type of brick and mortar in these smaller areas, because we know how much of a presence that means for the patient, right? Rather than, as much as I love Salt Lake, which is where I'm from, it's hard for somebody here to say, oh yeah, I visit with my provider up in Salt Lake. It's like, well, guess what? We are also available here in a rural area where, yes, it might not be a 3 or 4 hour drive, but maybe it'll be 45 minutes. We can still get that eyes on the whole being type of perspective.
And which is really the appropriate way to do telehealth. One of the most important things you'll do as a clinician is know when to say when this patient just is not appropriate anymore. What's your backup plan? You are obligated to, make sure they are cared for. If you set up only telehealth, what are you going to do when that anymore? So I think those little centers are, you got to come in next time. Sorry. And I work in addiction, so it's like, yeah, I'm not feeling well. Okay, next time you're coming in.
And I think from the medical side of it, when you have a prescription that the patient needs, way easier to kind of use that as a carrot to bring them in.
Yeah.
When it's strictly behavioral health, you don't have as much of that. But other I'd like to get to know you and the other systems that are affecting you. So let's do an in-person visit. Even if that means we have to be in a larger. Sometimes we'll do it in our conference room, right? So we can all have our own space where we can take our masks off and really get to know them, because even with the mask on, you're really not seeing as much as you would in that face-to-face interaction.
That's actually one thing I was going to mention. That's built into the new physician fee schedule now as well. That they just released, CMS just released the 2022 fee schedule. One of the things it says is an in-person visit is required within 12 months of the telehealth visit. the proposed fee schedule had 6 months, but they've actually extended that to 12 months. So they want to see patients
Yeah.
come in for an in-person visit every once in a while, not
Yeah,
just.
I will say that for me, working with urban and rural, you know, in Price and Four Corners is pretty rural. The hard thing for me has been just the system. Here I am, a University of Utah clinician. I mean, it's push of a button for me to get IT and you know, I just have people at my fingertips that can assist me with this telehealth appointment. And in rural, the numbers aren't there, the people just aren't there, and the systems just may not be, of course, what you know, urban system might be. And so you have to hire providers that are real troubleshooters and are interested and invested in the whole experience, because you know you end up having to play a lot of roles, especially in places where you just don't have a robust support system.
So we talked a fair amount about telehealth in the process. A lot of it seems to be behavior work and be dialogue, and that's the major treatment. Can you just speak briefly about the where we are in terms of telehealth that needs blood pressure and other sorts of biological measures? Is that moving along, and are we coming with cost-effective ways that in remote settings we can get data about beyond?
Incredibly creative ways. That's what's impressed me with primary care. There's Danielle Pendergrass is a nurse practitioner in the Price area. She created a video in that toolkit that I put together and it's on the NRTRC site. And it's just so creative. It's flashlights. And you almost, these are like ideal. You ask your patients to have a bag like this that has their own blood pressure cuff and thing. And you know, I think that's how primary care is getting around this, is just sheer kind of creativity in a lot of occasions. And again, asking the patient to be a partner with you. And, you know, do you have your scale here next to the computer? And can you leverage a care team member, like a family member, to assist you? And can you hold the camera a little bit while this person shines a flashlight? I don't know how they're doing it. It seems like a lot of energy, but people are real creative.
You know, honestly, I don't know as much because we're a little bit more urbanized, working here in Washington County. I'd like to think, I remember some discussion about some of the home medical clinics, not companies, that would say, hey, we have this and that we could send into the patient's home, and they could use it for a while until they're there, and then rotate it around. Truthfully, I don't know how often that's happening.
It is happening. The technology world is exploding for peripheral devices, wearable technology.
Pano cameras.
Yeah, and you know, we're doing a project right now, school-based telehealth. We've been placing these small telehealth kits. It's a mobile kit with a digital stethoscope, a pulse oximeter, a blood pressure cuff. Nowadays, they even come with a small handheld digital. Well, they have EKG, but they also have
Blood sugar monitors. Okay.
they have blood sugar monitors, ultrasounds, small digital ultrasounds, high definition cameras. Emergency rooms are sending patients home with the pulse oximeter and having them monitor at home and report that data back. We're definitely getting there. The technology is there.
And insurance is starting to catch up and pay for those efforts. That was one issue for a long time, was if you can get money. Now you can, you know, sending an X-ray to another provider and taking that data and, you know, putting it in the chart is all getting billable finally.
So let's talk reimbursement. That was a big issue, and especially during the pandemic, we've had different systems here.
Matt.
Yeah. So yeah, I mean, I talk to people all the time about really one of the #1 drivers of telehealth adoption is reimbursement. And that's where all the regulation and rules are. So the pandemic has been the greatest thing ever for telehealth in terms of relaxing regulations. Making available, telehealth available for patients in their home, in urban areas as well as rural areas. They expanded the type of provider that can be reimbursed for telehealth to therapies, physical, occupational therapy, speech language. It added, CMS has added almost 100 new codes for telehealth specific services. So we've also seen at the state level, states are starting to implement payment parity laws. I think we're up to 7 states now that actually have a payment parity law that requires insurers to pay the same rate for a telehealth visit as they pay for an in-person visit. Utah is not there. Utah has a coverage parity law, so that the same services you offer have to be offered virtually as well. We haven't gotten to the payment. But on our website is one of the main resources I wanted to share. We developed a telehealth billing guide that goes through basically every code available, a description of the code and the reimbursement amount for that service. So you can read that, and especially during the public health emergency, there are category 3 codes that the new physician fee schedule has extended those codes out until December of 2023. And those are codes that are basically only available during the public health emergency. So they're good to be aware of. After an hour about reimbursement.
You know, when you look at the CMS document, you go, I wish someone would just condense what I need. That's what Trudy Bearden did. That's that document. It's worth downloading.
But yeah, it does always come back to reimbursement and providers get paid for it. And if they get paid well for it, they're more likely to adopt it.
And the health insurance companies of Utah, the stakeholders, they do join us at our Utah Telehealth Network conference. They do want to, talk about this. You don't necessarily see eye to eye. You don't all see eye to eye necessarily on it. One of the big pushes is to decide, is this equal work? Is this less work than in-person work? Or is this in fact more work? And, they would like to make the point that, well, surely it must be less work. You didn't have to drive, there are all the, and you're going, but have you done it? Because there is a lot happening in a telehealth visit.
A couple of clinicians in here that are savvy about telehealth, and you guys had to learn it, what I assume after your education and training.
Yeah.
How do we prepare nursing students, medical students, other health sciences students for this new era of telehealth, so they don't have to jump onto the steep end of the learning curve like you had to?
Curriculum, you build it in. It's what I've done for my students. And simulation, put it into every kind of medical training you can. If you have an interprofessional education department like the University of Utah does, where health students from all disciplines come together and act out a simulation, put a telehealth piece in there. Just start to integrate it. As Matt said, we got to stop thinking of it as this separate thing. It now just is a piece of kind of everything you do, building up, or you sort of do what the state of Washington has done, and you say, if you want to do this, you have to have a certificate. You have to get some sort of training. You have to have X number of hours proven trainings and have a certificate, and then you're approved for it.
Any role for modalities like virtual reality, augmented reality?
Yes, I have an idea for VR, but it seems like a little down the road. But I think it's a great idea. You had a question.
Follow up on that. When you think about bedside teaching, or we have a student on a team and it's around the bed, and the student is present with the other team. Are we developing models for that in telehealth so that the student is present in that telehealth visit in an appropriate way? And often we think of it person to person, camera to camera.
Yeah, I think that it's, yes, you you know, you include students, you connect patients and students and the whole team any way you can. And so we make that work with telehealth. I have a student who lives in Jackson Hole. She's with me every week. I carry her around.
And I think that would be something that I would add, is have somebody who's a champion, right? Like Zoe in that situation, she's carrying that student. So if you're gonna do a group setting where you're trying to train, have somebody who's really in charge of making sure that person who's virtually has the same experience as those that are there.
And that actually is the term, is the champion, the telehealth champion. It's what we're finding is one of the key pieces to creating an effective telehealth program is having a champion. And it's often a clinician, but it doesn't have to be.
We have three universities now, University of Washington, Gonzaga, and the University of Utah that are requiring their students to take our telehealth 101 course as part of that curriculum. So they're finding our course and building it into their.
And when you attend educational conferences, you know, everyone's talking about it. It's coming. Everyone realizes it must.
I maybe have a question on that curriculum aspect that you guys are talking about. Anecdotally, I find that maybe physicians and practitioners that have been in the field longer are more resistant to telehealth versus newer physicians. And typically, it is the older physicians who are teaching the new physicians. So how is that? Maybe the curriculum is there, but this is important kind of emphasis or emotion is lacking.
Yeah.
What are your thoughts on that, and where do we go with that?
You can require every one of your clinicians to take these courses that Matt's saying, and hopefully in those courses, I haven't been through one, but it starts to talk about the value, why would you be invested in this, and maybe just shift the perspective for older clinicians. I mean, I lived through a time when we moved from handwritten charting to EMRs. And I mean, you know, now it sounds absurd to think that someone would give pushback, but they did.
And as we look back at the EMR adoption, we found many workforces decided it's time for them to retire.
Yeah.
Unfortunately.
I think I think much the same way.
If I could just follow on that, so I was previously the Associate Dean for Graduate Medical Education at the U, and I've done it both as a clinician, so pediatric ICU, and we all had to take a course before we started offering telehealth to greater amount of facilities. And there was variable, and I do think there was a bit of an age. I had done it in the military, so I was even though I'm on far end of the age, I was more comfortable with it. Some of our folks were not. But what we found, and it's true, especially with residents and fellows, most hospitals, when they contract, they want an attendee, but they will allow like a trainee or student to participate, but like our fellows can't be the primary, even though by phone, they're often the one guiding them, but by telehealth, they wouldn't for a lot of reasons. Well, what we did, and I think the champion, I like that term, I hadn't used that. We found some younger faculty who were really good, and they became kind of the education champions for the trainees. So even though all of us did it, we found people who were younger and engaged and could really teach the fellows how to do it, rather than someone who didn't really like it.
I had someone had a great suggestion. I read the article or something, and it talked about taking your healthcare students in this interprofessional setting and where they're learning to work with each other, and then bringing technology students and really start to collaborate on. They're a crucial piece, and yet we don't think of the technology people. Part of this that they are, of course, we cannot do anything without them.
I have one other thought to that question, though, because it's something I've thought a lot about. I think it's really important as we do kind of come out of the pandemic. So at the beginning, it was let's do all of our visits with telehealth because patients can't come in. Now that it's going back down, I think it's around 20% of total care still being virtual. I think it's critical that providers start to find where it's most appropriate. So you take those, I won't call them older, maybe seasoned providers, and I think that they really like the follow-up, like the medication management follow-up visits, because they're quick, they're easy, patient doesn't have to come in. So you find those visits that are most appropriate for for telehealth and have them use those primarily because they don't want to do everything virtual, but then that starts to help, I think, bridge that gap between those that don't want to accept it fully, but I'm okay with it in certain circumstances.
The other thing that we've done to add on to that is that Friday evenings, we close our clinic because nobody wants to work late, except for we will have a provider who still does telehealth visit. So that just increases our access to care because most of the clinics are closed at 5 on a Friday. But we've been able to prevent some people from going to the ED because we can have those virtual visits.
And here's a clinician that's going, yeah, I'd love to have my Friday off and work a few hours. And telehealth opens up a lot of opportunity for creative care. And when I was at the VA, our team was everywhere. There's a physician on his ranch in Montana, and, a psychologist that was taking care of an elderly patient in a high rise in Chicago. And it was, and we got the best. I mean, we had some of the best providers because we could pursue them from anywhere and give them, yes, you can still live on your ranch and work full time. Wow.
And so from a workforce standpoint, it does open up doors. What other disciplines in healthcare do you see coming online with telehealth? Is there a role for other opportunity like optometry, physical therapy, occupational therapy? Those
It's shocking how many disciplines have figured this out.
Yeah.
I mean, one of the first to do was Burn, right? So Burn has been doing telehealth for years because there are so many patients being treated in Salt Lake that are Burn. Appropriately said, but from surrounding states, and of course they make long-term care. So I think, and that's all about technology. That's about having a camera that's so powerful that you can really actually see what's happening. So yeah, we're talking about it now, but I think that people have figured out how to use it in creative ways for a long time.
I'm curious, because we talked a little bit about which providers are more adept or seem to adopt it better. Are there certain patients or age groups or demographics that tend to adopt this better? I mean, is it just kind of as we assume that younger people are more comfortable with this?
Yeah, they're more fluid, I'd say.
I would definitely agree. One thing that we've noticed is that we have a pretty large Hispanic population in the street. And one of the things that we've noticed is that often they will live with other family members. And so even if the patient might be a grandma or a grandpa, they often will have a grandchild who does know. We can at least help them get connected and then the visit facility.
So I guess a follow-up to that, is there a potential, I assume I'm a silly question, but at a personal level, I saw a physician, need to have some blood work. I needed to go up with the physician, get blood work rather than going in. It's an easy conversation. And the telephone word worked just fine. But I had to go through the process with this is one of the clinics up in Salt Lake at the university, having to schedule the telehealth thing. And I looked at my physician and we talked about my blood work. And it would have been just great over the phone. But are we now in a mode where we're sort of insisting on a protocol? It could have been just a phone years ago.
Again, a lot of it comes back to reimbursement.
Uh-huh.
And what will be paid. And so the trend that I'm seeing, especially from CMS, is that audio only telephone visits are going to be reimbursed going forward, but a lot of it is for mental behavioral health services and not for medication. Talking about.
But how about a sort of a text exchange conversation?
This one would have been good enough.
Right, and there is a lot of that starting to happen. It's such real time that it's almost the same difference. And maybe we just need to have new terms because that wasn't exactly a sort of follow-up appointment. Maybe we need to find a term for a quick exchange of patient provider information that doesn't require a lengthy, telephone.
I love your expertise and comments on reimbursement. Speaking to that, telehealth is almost a perfect caveat for value-based care systems or capitation models of things, right? Do you think that telehealth is a good way to kind of champion that to fee-for-service or profit-driven healthcare systems to switch their reimbursement model? Or do you still think that there's other things that need to happen for us to maybe move away from the fee-for-service?
That's a really good question.
And I know it's maybe a little rocket, so, but like, just your thoughts are great.
Yeah, I think it has the potential. Do you think it has the potential?
I would love for it to.
Yeah.
I think, does it make sense? Absolutely. I think telehealth, to me, right, telehealth and value-based, I mean, how do you keep people out of the hospital, right, versus getting them in? And for rural health, this makes 1,000 times over sense, right? Because rather than driving 5 hours to see my doctor, you know, I mean, what are the models there? But there's such a big fee-for-service looming and CMS, and you know, how do you start to challenge that status quo so it even makes sense for viability? Does telehealth help us bring that?
I'll share an example. I know one good example where that's working. I've heard it actually in 2 different places, but a rural EMS department, right? They get paid when they transport a patient to the hospital. That's how they get paid, right? So a rural EMS department teamed up with a rural hospital who was trying to transition to more value-based payment model. And what they do is they're coordinating, and the EMS department will do telehealth visits with patients rather than having them go back in the emergency room. They're reducing the hospital's readmission rates. And when the hospital sees a financial benefit to that, then they're paying the emergency department for helping them reduce their readmission rates. So they are finding models to incorporate telehealth into what the hospital is doing to transition to value. But I think it's a good question because there's not a lot of models yet, and we don't exactly know how it works.
That's a great thing.
But I think it will come out of rural communities when it does happen. I think it's the rural communities that are going to figure it out a lot faster.
Other questions that anybody has? I know our panelists may have some last words that they want to share, or any opportunities on the horizons, or things we should be watching for in the next few years.
I would just say telehealth is here to stay. I really think that we need to learn how to embrace it and kind of make it work for us rather than digging our heels in and saying, okay, once the pandemic is over, then we're not going to be on telehealth. I think it really is a great service for patients, and I know that if they're a little bit more acute than these, it's totally worth it. So I don't know, I'm thankful for the experience that I've had to do telehealth, and that I continue to do so because I know the patients are so appreciative.
We talked a little bit about training future providers to be telehealth savvy. What do you know of that we're doing to help the patient population become telehealth as the consumer becomes savvy? Are there tools or short courses?
I personally send out a thing to my patient that says it's essentially like you're a patient partner in a new special way, and these are some things that you need to remember, for our visit to be this, and have you turned off all of your browsing again. Patients don't know that running Netflix on their computer while a telehealth visit could be why you can't hear each other. So, so I send out a little pre-letter, and then I do gentle corrections. Hey, Judy, I'm pretty much just looking up your nostrils, you mind shifting a little bit, or I can see you're walking as I'm getting seasick. We'll just pause, and once you get to the place that you want to sit, so I personally do a lot of gentle coaching. This is new for everyone, and patient, sometimes they'll try to steamroll you a little bit.
I will share that our center is working with the VA and the State Office of Primary Care and Rural Health to develop a program for rural veterans, where we would place college students in those rural communities to partner and open hours in a public library or at a hospital or clinic where vets could come in and use the vet system. So I think mentoring them along is going to be critical.
The NRTRC, our website has a patient resources section. We've got checklists for what to do in preparing for a visit.
And they're printable. When I created my curriculum, a lot of the patient stuff was printable.
So there are.
That seems odd. Printable materials for a, telehealth or virtual.
But you know how you crave it sometimes?
Yeah, I do,
Yeah, I
but I'm an
know.
old timer.
I know.
Just financial incentive, I was thinking like you're incentivizing office hours beyond maybe the regular hours, and more volume, but there anything around like financial incentives or like free visits or something, just to get people to try it?
I always think it's incentivizing care is, I think that works so well. But
What do you
I
mean
don't-
by that? Because you can't really incentivize, like, give a patient a free visit. Because of
You can give them things, it
the
helps,
non-monetary. You
That's
can't
right, that's
reduce the
right.
price of,
it helps a lot in community mental health places where make your visit and put your name in a raffle or,
got it.
things like that.
Starbucks card.
Yeah.
How often do you deal with the challenges of equipment failure at a bigger scale, like the network scale? So back in the Four Corners area, they had 2 towers malfunction for some reason. And so 3 out of 6 clinics were not working.
Yeah,
And
what
there
it
was-
impacted a day.
yeah, employees could email each other, phones weren't working. How often does that happen? Are you trained to handle those types of disasters?
That's a great question. Trainings and guides for what to do in the event that you lose the technology. That's something that. Because it happens, right? I mean, our
Especially in
network,
rural places.
the uptime of the network is 99.9% across the network. Everybody's staying connected, but there's always construction going on, and lines are getting cut, those down. Usually not for very long. But yeah, definitely happens, but having some kind of guide or tool for what to do in the event. And it's getting more important because, the telemedicine platforms, cloud-based, EHRs are now mostly cloud-based. Everything's dependent, the phone systems over the VoIP, the IP system. You kind of lose everything.
Whereas in person, you could limp along for the afternoon.
I had somebody tell me that everything will work fine as long as nothing changes.
Well, we want to thank our panelists today and willing to share information, so reach out to them. They'll be here the rest through lunch, so get their contact. Thank you all for being here. We are going to be convening at noon back in the ballroom for lunch, some awards, and then our lunchtime speaker. So join us.